How you doing, Barbara?
I'm fine. How are you
Good,
doing?
thanks.
Good.
So is this Chinese restaurant already good?
This is what I've been told. First, I don't find that there's two sides to the restaurant. So the Chinese side, to me, isn't that great. I like Beijing Palace, which is a little further down the road.
So she's not.
But I've been told, and I'm not a sushi eater, it's really good to go eat sushi.
I just like that. So it's Japanese. Is it Japanese place or Chinese place?
Please enter your conference ID. Press the pound key when complete.
Because it serves all the normal stuff, like General Tso's chicken or whatever that you can get.
So your suggestion is get back out on Carson and head further down?
Yeah, I like Beijing Palace at Clearview, that light right before it starts to go down towards up to Tahoe. Clearview where the AM PM is.
Right.
And
But the individual exchange is where we think most
turn
of
right,
it
we
is.
go
So
up.
you're going way past Capitol Ford.
Oh, yeah.
You're going way down.
Way down, we're going like 2-3 lights.
As soon as I say that,
They don't jinx it, or they don't have to
Where
work.
where the AM is, there's a.
No, small employers in general.
You'll see it at Landmark Shopping Center, and you'll pass it. It'll be a little.
I don't think that they're that financially.
Stop sign, you'll go through it, turn left. Strip center, and you'll see the Beijing Palace. I think it's the best. Everyone has their own Chinese food.
I was gonna say, unless you're a well-established small employer with a really good
They're
structure,
quick.
which really good business structure, which means a larger small.
Go eat there.
Yeah, the mom and pop smaller organizations,
Like,
they're
if
just
you order your food, I kid you not, it feels like 3 minutes.
they're gonna say, I don't have time to deal with this. They're gonna look for the easiest, cheapest route.
I know, I have one small group, I'm sure.
It's like,
I find it's a step above run-of-the-mill.
canned chicken and all that kind of stuff.
I find it to be better.
You know, but he does want to.
Everyone has their own, some people like Pan Kitchen, some people like,
Right?
whatever they like, they have their own payout, just like they do with
This whole
burgers
case
or
is
with American restaurants or Mexican food.
Yeah.
If I'm eating Chinese, it's the only place I'm going to eat. I've eaten at every Chinese place here.
I don't know about that.
I know. Well, on the agenda, they put building.
Because we sort of front the money for that, but then some of that stuff's come back into second 2012.
This might be our last committee meeting.
That's what I told.
Cross your fingers. Don't jinx it.
Reminds me.
What did they just say? This can be
Well,
a
every division sort of
Might
eats what it
be,
kills.
might be.
So we make what, we
Might
pay our
be.
bills, we make what.
Might be. That's right, they can always call us back at any time.
All right, good morning, everyone.
Yeah.
It's 10:30, and this is the time and place for the certification meeting.
Can you hear us in Las Vegas?
Yes?
Yes, we can.
College subdivision. We're going to go ahead and start the meeting then. I'll go ahead and have the executive director
Problems are our
roll
own.
call. Just look.
I have the roll call for the board meeting this afternoon. Why don't we do it this way? In Las Vegas, can you please state your name for the record?
This one.
Vicki Mayville for the record.
Vicki Mayville?
Wayne Finch.
Richard Roberts?
Dr. Roberts?
Yes.
So I finally learned.
Yeah.
Who else we have down there?
Well, we have Dr.
See
Klein
Dr. Klein
Everybody back?
and Wayne Finch.
Here.
and Mr. Finch.
Sorry.
And in the room here,
Steve Woodley?
Mr. Woodley. And Madam Chair.
Yes, here.
And do we have any board members on the phone?
All right, so,
All right, so we have 6 out of, 9, so we have a quorum.
okay.
It looks like missing is Dr. Ash Jackson
And Dr. Ahern?
and Dr. Ahern. That math
And,
doesn't work.
Dr.
Oh, and Mr.
Mathias.
Mathias.
All right. So I don't have any announcements this morning. Do you, Mr. Hager? Just if you're listening in on the phone, please be sure and mute it so that we don't get any background feed from your telephone or your office locations. I'll go ahead and open it up for public comment. Do we have any public comment here in Carson City? And come forward, please, and identify yourself for the record. Sure. And the agenda, I think, properly notates that public comment should be 3 minutes or less.
I'll put my fast track shoes on. My name is Dennis Spain. I am the Chief Dental Officer for Nevada Dental Benefits. We are a dental HMO in the state of Nevada, domiciled in Nevada, that we take care of approximately 150,000 lives in the state today. You have 2 items on your agenda that I would like to speak to that you are going to consider. First item is the approval of the network adequacy document, which I think is by and large a pretty, we're very comfortable with that document, with the following exception. If you look at page 5 of 5, the last 2 bullet points that are in this on that page at the top, there seems to be a bias about HMOs and PPOs, which I don't quite understand. It raises a bar that the HMOs have to reach that is significantly higher than the bar that the dental PPOs have to reach. Dental HMOs usually accomplish a much better discount than a dental PPO, and oftentimes people are willing to have a longer distance to travel to get a greater discount. Therefore, it places us at a rather difficult disadvantage relative to our competitors, the dental PPOs. And I would give you an example, since I'm going to be the one probably having to attest that we have reached the network adequacy in the areas which we market. The difference between a 50% attestation and a 95% attestation, it goes as follows. Today I would attest that over 50% of the people in this room brushed their teeth this morning. Easily. I put my paycheck on it. But I'd be a little bit more reluctant to do that if the standard was now 95%. And what I would have to do to assure a 95%, the steps that I would have to go through, are a bigger and a significant burden on the dental HMO. So my recommendation to the committee would be simply to strike those last 2 bullet points, because I think your document stands well enough without them and does not burden the dental HMOs unfairly. Either that or burden the PPOs to the same level. I'll take either side of the argument, but I think that the document is sufficient the way it stands. Dental networks are market-driven, and they are impaired by provider informal boycotts. Plans seldom can drive a network, particularly in dental. So I think that the market forces that are going to impact how these plans function and how wide in the state they function really is going to be controlled by external forces rather than the plans under the plan control. The second item you have on your agenda today that I'd like to speak to is the item number Roman numeral 5. This is such a flawed document, I don't even know where to start with it. Let's begin with the idea that pediatric essential health benefits is an essential health benefit. And to conclude that this is an option does 2 things. One, it makes it probably impossible that we'll ever get this back on the agenda again as a service provided through the exchange. But more importantly, it totally destroys the underwriting of those plans if you make them voluntary. We are all struggling right now with the actuarial value methodology that's being applied to the CHIP plan. I've hired actuaries. We're going to make it, but it's a real struggle to try to figure out how to do that. Now, if you make that plan voluntary, it throws all of our work into a cocked hat. I'm
going to ask you to stop just for a minute, please. I think this public comment is important. Do any of the committee members object if we let it go past 3 minutes?
No.
Okay. And we may want to bring you back during that item as we go forward, so.
And maybe that's more appropriate, Madam Chairman. I'll take whatever recommendation you want to make. There are specific items in Roman numeral 5 that are in conflict with each other and in conflict with the intent of the legislation. And I would like to speak to those as you begin to work on them.
Why don't we take public comment when we get to each one of those items then?
I will excuse myself. Thank you very much for your time.
Thank you. Do we have any other public comment here in Carson?
Yes, good morning. James Mullen with Delta Dental Insurance Company. I've spoken with you before, and I'll be brief. Listening to the gentleman prior, for the network adequacy standards, we were invited to provide some feedback on those, and we did so. My understanding is that the percentage thresholds, I'm not sure how they were established, but that until you're in the exchange and you have some enrollment, you cannot measure your capability of meeting the thresholds. And there will be an opportunity for you to try to mitigate if you fall beneath the thresholds, which we are content with. So we would just go on the record on that. As to the required offer versus required purchase, we would contend that we'd be perfectly happy if it is a required purchase for pediatric age children, not a required purchase for all the population. Department of Health and Human Services, however, has ruled that the pediatric dental is only a required offer. That could be why you are looking at that potential option. But we would have no objection. We have rated our products as a voluntary product, which our actuaries can do, but it is a probably safer rated or better rated product when it is a non-voluntary, because you can have a certain measure of expectation about what type of enrollment you might get. So with that, I'll also join the conversation as you begin to struggle with these issues later on. Thank you.
Any other comment here in Carson? How about down in Las Vegas?
Seen a comment.
All right, is there any comment on the telephone? Okay, hearing none, I'm going to close agenda item number 2 for public comment and move to item number 3. Do we have any changes, edits, or amendments to the minutes from April 18th? If there are none, may I have a motion to approve?
Move to approve.
Claire Mathias, second.
Okay, Dr. Ash Jackson made the motion, followed by Mr. Mathias. All those in favor of the motion?
Aye.
Any opposed? Okay, motion carries. Thank you. All right, agenda item number 4, adoption of network adequacy standard for standalone dental plans. Oh, Mr. Haycock?
Damon Haycock for the record. Today I'm going to bring this report to hopefully provide a recommendation to forward to the board to adopt the attached network adequacy standards for standalone dental plans. Last month I brought to this committee and then again to the board the network adequacy standards that were recommended for medical qualified health plans. The standalone dental plans are following a very similar format, so this should be pretty easy to follow. One thing I want to address initially, of course, is the background on this. On March 14th of this year, the board approved standards for certification of standalone dental and vision plans, which included that the standalone dental plans should follow the requirements of 45 CFR Part 156.235 as appropriate, and of course essential community providers are available. So these standards that I'm about to go over have been vetted by members of the dental insurance industry, as you heard from public comment already. And so I'm going to direct your attention to the attachment at this time. There are 11 sections, just like there were for medical qualified health plans. And I'll briefly go over each of the sections and concentrate a little bit more on Section 7 about essential community providers. Similar to qualified health plans on the medical side, Section 1 has a general requirements, which discusses best efforts to maintain each product provider network, that oral health care services to covered persons will be accessible without unreasonable delay. Also, that provider directories must be updated online, no less than every 90 days. Section 2, submission and updated processes, discusses how this will be submitted to the exchange through SURF under the Network Access Plan cover sheet template, as well as an attestation form for compliance with these network adequacy standards. Section 3 is referrals and reimbursement, discusses absence of or an insufficient number of providers or facilities, and that referrals will occur within reasonable proximity to a covered person at no greater cost to them. Section 4, reasonable effort and relative availability, discusses the reasonable proximity of network providers and facilities to the business or personal residence of covered persons. Section 5 is the disclosure of the network limitations. Section 6 discusses the coverage of facilities within the Indian healthcare system and how covered persons must have access to the Indian healthcare services and facilities that are part of IHS if they are American Indians and Native Alaskans. Section 7, the essential community providers section, discusses the essential community provider requirement. Now, there's a couple keywords that need to be discussed or need to be reviewed. That a carrier that is participating in the exchange shall use best efforts to have a sufficient number and geographical distribution of essential community providers where available, and that's key. Because at this current time, there is a non-exhaustive list of essential community providers that is out on the Health Resources and Services Administration, HRSA's website, that CMS uses, and on that essential community provider list, there's only 2 essential community providers for dentistry statewide. And so although there is this language that mirrors what the regulation says for essential community providers and that we use for qualified health plans on the medical side, of at least 20% of available ECPs or 10% plus a justification letter, the exchange fully recognizes the daunting task of trying to find essential community providers where none exist. And so Section 8 discusses the establishment of reasonable criteria and that there's an adequacy of choice establishment by the carrier for reference to any reasonable criteria, including such things like provider to covered person ratios or geographic accessibility, among others. Section 9 goes over participating provider availability and accessibility standards. This shows, of course, the maximum travel distance or time based on specific geographical areas by county. That the standalone dental network must have 1 general dentist and 1 dental specialist or facility within the travel standards for each of those counties. And you'll see that there's a mileage and a time distance. Also note that it is footnoted at the bottom that every consideration will be given by the exchange to the relative availability of oral health care providers or facilities in the geographical area when determining if a carrier meets these above established network adequacy standards. Section 10 then goes over what the goals are for the provider network adequacy. Adequate number and type of providers, geographically accessible, sufficient providers of all types. Then, of course, with the public comment, the last 2, compliance, 95% of the population of that geographical service area for HMO membership and 50% for PPO. And the last section, Section 11, provider network requirements, kind of finishes off this document here. Adequate number and types of providers must comply with the essential community provider requirements. And of course, that provider directory must be available for publication online and in hard copy upon request.
If I could add a couple things.
And yes, but then after you add, maybe this is part of your comments,
Yes.
though, I'd like to find out why the percentage differences that
Sure.
came through public comment on section number 10.
So for the record, John Hager, So first of all, there are a couple differences behind how this is going to be done compared to the medical network adequacy standards. Currently, there is a bill before the legislature, AB 425, that will create statewide medical network adequacy standards. There is no such provision for dental. I believe there are some very light network provisions in statute, but I'm not sure how applicable they are in this case. These standards are, I don't know if they're more stringent, but more specific than the standards that are laid out in statute and regulation at this point. And the DOI has indicated that they will not be creating statewide dental plan network adequacy standards. So this is only for standalone dental products offered within the exchange. That's the first thing. The second thing to understand.
Dr. Klein, was someone asking a question?
No.
Okay, thank you.
The second thing to understand is that there is a provision, so the way that the market is being treated inside the exchange and outside the exchange according to CSIO's rules is different, and that's because of the way that the ACA was treated. There is a specific exclusion for dental plans for the pediatric dental benefit, which allows for standalone dental plans. And the rules from CSIO indicate that there is no requirement to purchase standalone dental inside the exchange. Outside the exchange, if a person is going to purchase a medical plan that does not have the dental benefit embedded in it, that medical plan is required to receive a reasonable assurance from the consumer, and that could be an attestation, but a reasonable assurance from the consumer that that individual has purchased a standalone dental plan that has been certified by the exchange. So anybody who is enrolling, and I think the way the logic works out is anybody who's going to enroll in a medical plan off the exchange, if it doesn't have the dental plan and dental benefit embedded, will be required, and I put required in quotes because it's a reasonable assurance, but be required to purchase an exchange certified dental plan. Therefore, they could not purchase a standalone or purchase of a standalone dental product that is not certified via the exchange would not satisfy that requirement. So it's kind of an interesting concept. So outside the exchange, you have a situation in which, and this will become more important for the next item, but it kind of relates to this. But outside the exchange, you have a situation in which individuals are, again in quotes, required to purchase standalone dental products certified by the exchange. Whether or not they do that, I don't know. I don't know how much the carriers will follow up on that. I don't know if that's simply an attestation thing and how many people will just lie to get out of it, or how many people will actually be honest.
Madam Chairman, I'd like to make a recommendation that we table this until we deal with number 10. Because I think it becomes more or less relevant depending upon the decision on the recommendation. Because you've gone into this now, and it's extremely murky.
Yes.
Around what the expectations are. So my recommendation would that we deal with 10 now, and then come back to 9, depending upon what the expectations of the 10 are.
What is 10?
I'm talking about 10. I'm talking about the one I'm upset
Section
about.
10.
Percentages?
No, I'm sorry. I'm talking about the recommendation to embed or not to embed.
Number 5.
Number
Versus
5.
number
Agenda 5.
Yeah.
So I would
Numbers always get people.
recommend that we go to agenda 5.
You know,
and
times I
we
order a
take
factor
this till we
13 and
deal
get a
with
factor 8
agenda
level.
5, because it becomes either more or less relevant.
And Mr. Hager, do you feel that the background that you're doing right now will be important for us to know
For both.
for both?
That
Why don't you let him finish his background,
Makes no
and then
sense.
we can move agenda items around. Pleasure of the committee.
So my main point for discussing that piece of it was that this will impact outside the exchange as well as inside the exchange, just like our decisions on any qualified health plan. The other item, again, essential community providers, we want to emphasize that we need to work with the dental carriers to try to make sure that this item is complied with. But again, if there's only two, there's going to be at least 2 service areas, potentially 3 service areas out of the 4 that there will be no ECPs in. So we need to be aware of that. And then the last thing was the 95% versus 50%. And to be quite honest, these standards were basically copied from the medical network adequacy standards and adjusted, and we may not have caught everything. And so so the difference between 95 and 50 for a medical PPO network, that becomes more relevant, where in a PPO you can go out of network to get coverage, whereas in an HMO network you can only get coverage within the network, and that's why there's a difference there. And that may not be appropriate for dental, we recognize that. I would ask that, we do think that it is appropriate to have some percentage there. We recognize that there may be some shuffling going on when you get enrollment, and it will take some time to adjust to that. We do think there should be some percentage. If it needs to be the same percentage, that makes sense. I would ask the committee or the public to determine potentially what a good percentage might be. The testimony was, I can guarantee that 50% of you brush your teeth. Well, 50% may be a standard, but it might be too low of a standard, where 95% may be too high. So there might be a standard in between that would be appropriate for all plans.
All right. Does anyone down in Las Vegas object to us going to agenda item number 5, taking these out of order?
No.
All right, thank you. All right, who's going to do the presentation on number 5?
I'll do number 5.
Okay.
For the record, John Hager. So one of the very first flaws that you'll see in this is that embedded is spelled with an I instead of an E, like we talked about during the minutes of the conversation about the minutes of the last time. So pretend it's spelled with an E, first of all. So the reason this came back to the committee, if you recall, the recommendation of the committee, the board approved recommendation, was that the exchange would not allow embedded dental products, that they would all be certified as standalone dental products, but that a carrier could provide a rider that would be certified as a standalone dental product. And our intent was that it would allow a carrier to provide a plan in cooperation with another dental organization or have their own dental organization, but that dental plan would be certified under all the same rules as any other standalone dental plan, to try and create an apples to apples comparison. The other part of this that makes it very difficult is the comparison online. So if you were to show a medical plan with dental and a medical plan without dental, first of all, you'd have to show, number one, that these plans are different because one of these plans does not have the dental embedded in it. Second of all, the prices will be different, and so we think based on the price sensitivity, and we could be incorrect, but theoretically, if you have 2 medical plans that are identical, except one has dental embedded, theoretically the medical only plan, because it's offering less or fewer benefits, should be a little cheaper. I don't know how much that is or not. So if you chose a plan that did not have dental embedded, then the next screen you would go to would be to purchase dental. However, if you chose a medical plan that had dental, then you wouldn't need to purchase dental, so you would never see what your other dental options are necessarily. So then the other proposed solution was, why don't you make the decision the dental decision before you choose medical? The problems with that are, number one, you have to choose medical to be on a dental plan. It's what we discussed before. The medical piece is key to the exchange coverage. Second of all, if you do that, if you choose a dental plan, then do you then disregard all the plans with dental embedded in it, or and not show them, or do you show them and say, and now you've got to decide. Now I know you chose dental. Now you've chosen a medical plan with dental. So you need to get rid of the dental, or maybe you shouldn't choose the medical plan with dental, maybe you should choose a plan without dental. The way to display that, I don't know what the right answer is to that. We don't know, we can't figure out what the right answer is to that. And perhaps over the next year or two, in exchange, we'll figure out what the best way is to deal with that. There are other issues in here that we discussed about how benefits are embedded, and apparently this is flawed, but it was our best guess, and we of course welcome input from the committee and from the board and from the public. The intent behind this recommendation, again, was to allow for that apples to apples comparison. Well, I guess I have to step back and say, why are we bringing this back? So that was the intent of what we were doing before. The reason that we brought this back is because, based on conversations with the Division of Insurance, apparently a rider cannot be certified as a standalone dental product. We were incorrect on that assumption. That because it is offered as part of a medical plan, it would actually have to be certified as part of the medical plan. It would actually have to follow the market rules of the medical plan, which are different from the certified, from the standalone dental plans, which have very specific exceptions in the ACA. One thing I would note is that CSIO has indicated that a state exchange is allowed to follow this route of only offering standalone dental products. The other thing is that I lost my train of thought. Excuse me. So CSIO's indicated that we can do this. We have so a carrier could go about this two different ways. They could either contract with a dental organization that offers standalone dental or a dental product, and then they would have to coordinate benefits if it's embedded, or they could have their own dental component, in which case they would, again, coordinate benefits would be embedded. For those organizations that have their own dental products, they could theoretically go either way. We have queried the carriers, and most of them do not have any real concerns at this point. Part of the issue is, at this point, redesigning their plans to embed dental when they have been setting them up to be standalone, basically standalone plans. At this point, there's very little time to be able to change that. Now, if we were to offer it to be embedded, it would still be an option, which we would, I guess, have to figure out how we would display that on the exchange. But in any event, if we were to allow it to be embedded, it could be an option, though I'm not sure how many plans would embed that. It's certainly a possibility. So I think that pretty much went through everything that was in here. There are some specific examples about illustrative costs, and it doesn't mean that those are the costs of the plans. It was attempting to illustrate how costs, the theory of how costs would be different between embedded and standalone products. It did not intend to illustrate the actual cost, and the proportions might be all off, but it was the idea of how a premium might be adjusted. And so with that, I'll be happy to take any questions.
Yeah, this is Dr. Roberts.
Yes.
For the record, I'd like to perhaps add to the confusion. At least I'm confused in my mind about this, and this evolves around the premium support that's given to qualified health plans for persons who qualify between 133th and the federal poverty line. And my understanding is that those premium supports are available to help pay for premiums for qualified health plans. Since qualified health plans are required to have to offer pediatric services as an essential health benefit, therefore pediatric dental services are also subject to the same premium support. So how do we propose to offer premium support to standalone dental plans in any of these scenarios that you mentioned, much less premium support to the dental plans or to the qualified health plans who might be willing to provide pediatric dental services embedded in their plan, but aren't offering adult dental services.
For the record, John Hager, so either way, the APTC is available for both the medical plan and for the standalone dental plan. I am not 100% sure how the APTC is applied to the adult benefit, or if the pediatric benefit is offered to everybody. It's called pediatric, but I'm not sure on that. I'd have to get some of the technical folks in on that. But either way, they are offered the APTC. So if you were to have a plan with dental embedded, the APTC would be based on the total premium of the second lowest plan. If the second lowest silver plan, if the second lowest silver plan, when you add up a dental plan without, a medical plan without dental and a standalone dental plan, if you add up the total cost for the second lowest silver plan and then base the APTC based on that total cost. So either way, we have a method to do that technically.
Okay.
Dr. Jack?
Yeah, Madam Chairman, Linda Ash Jackson. I have a number of concerns that I would like to go through. The first statement I have is that I understand that CSIO has made some inconsistent decision-making inside and outside the exchange, and that the underlying goal of the Affordable Care Act was to provide pediatric dental services to children, because in my role on a day-to-day basis, I see children that have huge issues that require now outpatient surgery to actually have their restorations performed because their mouths have literally 100% of their current teeth infected. So my concern is that if you do not let the carriers embed dental inside the exchange, and I understand that there are display issues, which I think could be explained and corrected by using something similar what Medicare Advantage does every year for its Med D and its Advantage plans with and without drugs and with and without other benefits. It's problematic to assume that and I need to preface this by saying that Hometown Health does not offer dental as a profit-making product. So I'm not trying to preserve any margin for our own company. But what I would say is that not allowing carriers to embed dental in their plans in the exchange when you can't have a rider is a problem, because you're basically, if I'm another company that offers dental, and I know that dental is a positive market for me in terms of a margin product, what you've done is just made my standalone dental, when I do have my standalone dental competitors, more profitable and given them additional market share, because it appears that the exchange can't figure out how to display something. Or because there are concerns around how the benefits are going to be administered, and I'd like to talk about that in a second. Outside the exchange, we are forced to embed dental in our plans for everybody, or ask our patients and members to attest to something that would lie. Now, the majority of our ability to rescind coverage, as well as to re-rate in today's marketplace, is dependent upon whether or not that patient knowingly and willfully lied. So now we're moving into an environment where we're saying, last year we're going to throw you out for not lying, but this year we're going to encourage you to lie so that you don't have to buy a more expensive plan. Not everyone who is unsubsidized will want to go into the exchange. And I have a personal problem with asking people if they want to save money to be more affordable, if they don't think they're going to use it, to sign an attestation that I understand CSIO has said they could sign that says, I've already bought it, and then just forget about it because nobody's going to check. I think that's a bad practice. As far as the benefits are concerned, there's nothing that says that a $2,000 deductible isn't an aggregate deductible, and that deductible for dental could be anywhere from $0 to $2,000, depending upon where they felt they needed to hit the pricing. So you could certainly, if you were a plan, put a $100 deductible on your dental plan that was for services that were not preventive, and you could choose to offer your preventive services at no copayment or coinsurance, so that the deductible, so those patients could be seen and evaluated for the parents. I'm concerned that we are forcing people into an exchange that they may not be comfortable with, as well as not meeting the original spirit of the law, which is to try to get kids taken care of. So I am opposed to the recommendation that standalone dental would be provided on the exchange. Thank you.
It's Ron Klein. May I ask a question? I think I'm about as confused as everyone else here. If I know this is based on CSIO and they're what they call things, but if a rider requires that you purchase a qualified medical health plan in order to purchase the rider, is it really a standalone plan? I mean, in other words, what I think I'm hearing is that CSIO has said you can't offer a standalone health plan without having guaranteed issue, and we don't want to do that. But if the standalone plan is something that's available for purchase only if you buy a medical plan within the exchange, is it still a standalone plan? I mean, I know we're talking about legal stuff and verbiage, but it seems like they're two different things.
For the record, John Hager, so the committee's original recommendation and the board's policy that is currently standing is that no medical QHP will embed dental, that if that medical QHP offers dental, it would be offered as a rider that would be certified as a standalone dental plan. And so what that did for us is it created that apples to apples comparison to get over the technical issues in the exchange, still allowed the carrier to offer that plan as a rider. What that did, and the way we defined that rider, was that basically the rider would only be available to that standalone dental plan rider would only be available to those individuals who enroll in that specific medical qualified health plan. The concern is, part of the concern is the guaranteed issue requirement that says that I believe it's all qualified health plans and dental plans have to be available to basically anybody. And that rider methodology does not make it available to others, anybody else other than the people that purchased that qualified health plan. And because of that, it would have to be basically treated as an embedded dental product and would have to be part of the metal tiers and part of the out-of-pocket accumulators and stuff like that. Outside the exchange, again, those rules are a little bit different. The part of the, where is it going with this? Complicated topics. Did I answer your question, sir?
Sort of. So I mean, what we're basically trying to do here is find a way to do what we need to do and have the federal government still say it's okay. And I agree that a lot of this is just the way it's displayed on the computer, on the portal, and so there should be a way for us to do this, although it might make the portal a bit more complex. I'm wondering if you can have somebody buy a health plan, and an option within the health plan would be, basically have it embedded in the health plan, but have a choice. So as you choose medical plan A, as you're enrolling, almost like when you buy gas and it says, do you want to buy a car wash for $6 more? Yes or no. I'm wondering if when you're enrolling for a medical plan, there could be something that would say, as you're going through the process, do you want to add dental insurance for this much more? And would that still be a standalone product, or would that be an embedded product? It'd still give people the choice.
It would be an embedded product, the way you're describing it, and it would be submitted by the carrier as two different plans. So they would have Plan A that would be the medical plan without dental, and Plan B would be the same medical plan with dental. So there's that option, or the option that we provided here was to provide the medical plan, and that carrier could still provide the standalone dental plan. It just wouldn't be limited to the enrollment in that specific, to the specific enrollment in that QHP. It would be available to anybody who was eligible for that standalone dental plan.
And Dr. Ash Jackson's concern, I'm trying to get my arms around this. So your concern is that makes it not profitable then, or more profitable? I sort of lost that.
My concern is that I have three concerns. The first one is, the first concern is that that for carriers who offer dental products, and knowing that dental is a profitable line of business, you're telling those carriers, I can't balance my benefits to something that I can't balance my benefits between medical and dental, where I might want to make a small amount of margin or advantage my pricing on the dental and then offer better medical benefits, however you look at it, because now I'm forced to offer medical only, because business that could normally be mine is going to go to a standalone product that perhaps could make those people offering that product more competitive than I am, because it would have greater market share. So that's sort of the insurance view outside Hometown Health. The second concern that I have is that the market outside the exchange for small group and individual will be a lively market for a number of reasons for the people who do not get a subsidy. And some people may be reluctant to go inside the exchange because they, at least in year one, may have the perception that it is only for subsidized people. They want to stay with their current plan. Now, when I renew their business or I sell them new business after January 1st, 2014, not only are their premiums going to increase because of the aggregate taxes and guaranteed issue and rate bandings that are mandated by the law, but I'm going to tell them, if you want to stay with Hometown Health or St. Mary's or Aetna or Cigna, I have to ask you, as a 60-year-old husband and wife, to buy pediatric dental that you won't use because CSIO says I have to embed it into my plan, okay? Or you have the opportunity to fill out an affidavit that says that I bought it, but some people aren't willing to lie. And if the entire industry coverage today is predicated, if we withdraw it, on whether or not someone tells the truth on their application, how can I advocate 1 year later that they should lie? And that's my issue. It's because you're making the market non-competitive by not allowing people to embed. And the pricing would be, you're forcing people into the exchange or to lie. And I don't know how to get around that, because I think that that's a bad practice. If you lie about that, are you gonna lie, you know, what else are you gonna lie about? I would have a hard time attesting to something that I know was not true.
For the record, John Hager, so I can't speak to the technical aspects of submitting health plans, but from the regulatory aspect, this recommendation is not supposed to disallow embedding dental plans outside the exchange.
I understand
So
that.
again, I don't know what the technical aspect might be of that
No,
that would
it's a
prevent it.
pricing differential. So for the sake of argument, if I'm inside the exchange and I offer a plan, and I offer that same plan outside the exchange, because my customers may not want to purchase through the exchange. They may find it, you know, they may not be comfortable with that year one. They may not believe in healthcare reform the way it's currently modeled, okay? Now I have to charge them for embedded dental, and I have to make sure, and so my price for that is basically, if it's the same plan, what I'm charging in the exchange for that plan plus the exchange fees inside, plus now I have to charge them across my entire population for dental, even if they have no intention of using it. Or I can offer a plan outside the exchange that doesn't have dental, but then they have to attest to the fact that they purchased it elsewhere. That's my problem. It's a pricing issue. It's anti-competitive for the market outside the exchange. And as I said, I really don't think we should ask people to lie. I think that, and I understand that's the way CSIO has set it up, but maybe they're comfortable with that, but it's not the way that we should do business.
This is Ron Klein. I'm trying to get, I'm sorry, and I'm lost, but I'm going to give Dr. Ash Jackson credit for knowing what she's talking about. Would it work if we just simply asked the carriers to basically create Plan A version 1 and Plan A version 2 with an embedded dental plan, and then just simply make a point in our web portal that, you know, people understand very clearly that, you know, there's a difference between these two plans. The difference is dental coverage. I mean, does that work?
For the record, John Hager, it doesn't change either one of our issues. In fact, that if you create two plans, one embedded and one without, then we've still got the IT technical issues, and you still have carriers. I mean, I don't understand.
But you don't have a free state.
I don't understand.
I'm getting away from
why this decision is saying that we're requiring somebody to lie. That's CSIO doing that, and so if you require everybody to embed dental, so you could do that. You could require everybody to embed dental, and then there are no qualified health plans offered off the exchange that don't have dental. So if you, well, I don't think you can do that either, but let's pretend that you could. Let's pretend that every qualified health plan in the exchange has dental embedded. Then outside the exchange, any qualified health plan would then have dental embedded, and there wouldn't be a lying issue.
Right.
But if you did that, then you are not allowing standalone dental products in the market, which we can't allow. So we have to allow standalone dental products in the exchange. Therefore, we can't require everybody to embed it. Therefore, if somebody has not embedded a dental product as a QHP, then if that product is offered outside the exchange, and I'm not sure it has to be offered outside the exchange, then you will have a situation in which somebody is potentially lying on an attestation. My understanding is that a qualified health plan is not required to be offered outside the exchange. So if the carrier is concerned about that issue, they could simply not offer that qualified health plan off the exchange.
It's not just the qualified health plan, as I understand it. It is the base benefit that is required, regardless of whether or not the plan is qualified. So if
It's market-wide.
It's market-wide. It is individual and it is small group, right? So it's not so much that it's a qualified health plan, it's mandated for individual and small group. So I think that's really the problem. So we have to sit down and enhance plans according to the essential health benefits that were chosen. And because of that, we have to embed dental in our products. And because of that, it becomes anti-competitive between inside and outside the exchange, regardless of whether they are qualified or not. And that's the issue. And again, I understand it's CIO advising people to lie, and I'll keep my political opinions to myself. I just, fundamental, and I understand that this was very difficult legislation to implement because it was non-specific and there was a lot of license taken. It's a problem for hometown, it's a problem for me that the market's being structured this way so that people are forced into the exchange in order to buy coverage that not every carrier may choose. I'll give you, for instance, suppose you offer an exchange and we said that there were 5 plans per entity. So suppose a carrier makes a decision to offer only PPO products that are licensed under the PPO inside the exchange and to offer their products on the HMO outside the exchange. Okay? For that market, they may offer their PPO inside the exchange, but they still have to embed dental outside the exchange.
Or they can,
So,
or they can provide.
So maybe I'm really confused, and if I do, I apologize. You know, if we go back 2 meetings, the whole reason we created a standalone dental rider, best of my recollection, was we wanted transparency, a much overused word, that people would know that there was a difference of plan was $500 and one was $400. It was because you were getting dental. That was the whole reason we did this, for clarity, if I understand correctly. So it seems like we could be able to go around this and simply go back and basically allow a plan to create Plan A version 1 and Plan A version 2, and then we don't have freestanding dental plans. We still give people the choice of whether they want to purchase dental coverage or not, and we comply with CSIO. As long as we do that appropriately on the web portal, we still get the clarity that we want. So unless I'm missing something, that seems to me something that would be a viable option.
And I'm not saying that we shouldn't have standalone dental plans in the exchange. That's not what I'm saying. I'm just saying that the playing field is not level outside.
Dr. Jackson, when you're talking about embedding dental in the qualified health plan, are you talking specifically about pediatric, or is it going to cover all
pediatric
dental for all?
Pediatric dental
only.
Only. All right? And then I think that, and then there's a decision about whether or not a broker or another carrier wants to sell voluntary adult. But I'm only talking about the mandated pediatric benefit, right?
And I think our original thought was for those individuals coming into the exchange that don't have children, what options they would have so that they're not picking up pediatric.
And that's exactly what I'm saying.
But that adversely selects the non-exchange market that are required.
So
would this be?
Just let me say that one more time. Maybe it'll help Dr. Klein and myself a little bit.
So if on the, Steve Woodley from the.
Am I the only one?
So if the ruling is that you have a required offer of pediatric dental for QHPs on the exchange, that's one world, and there's that enrollment. But if outside the exchange, small group and individual is required under the ACA to have pediatric dental, even if you're a childless adult, you must have it because the law says you must have it. you've created an adverse selection issue.
Okay.
So my point is, could you do the inverse, which is to simply say that you have standalone pediatric dental is the mechanism by which this component piece is offered. It is a required purchase in and out of the exchange. There are 4 carriers that will provide that service in the exchange. It's part of the rate up process. When you make your health plan selection, you pick your dental selection, you get a total premium. Outside the exchange, you pick the medical plan, you go to whatever carrier that the broker wants to take the employer to. There are 4 options. They represent the same 4 carriers that are represented in the exchange. There is a component premium piece that is a part of that. The total is added up, you've satisfied it, because it's part of the premiums calculated, and then the money can be reallocated. But to me, that just seems like the easiest way. It takes care of the time constraint issue that carriers have to not have to go and reinvent the wheel. It takes care of consistency issues across both playing fields in and out. And it also satisfies Dr. Ash Jackson's requirement that, pediatric dental is very important to the overall health of the child. So there's a lot of win-win in that. And to the extent that we could make that happen, it also satisfies the display issues that would come up. So that's my 2 cents worth.
But my issue with that would be that now you're saying that every carrier has to participate both inside and outside the exchange in the market to make that equivalent. So, and I would have, because there also are carriers who, for instance, if somebody goes in again with a PPO product and not the HMO product, and somebody wants a PPO outside, since we're not limited to the number of plans that we can sell outside the exchange, it becomes a problem because CSIO still requires that carrier to embed the dental. Now, if Mr. Woodley is saying
pediatric
dental.
Keep putting that in there, because I think that's what's
pediatric
confusing.
essential dental benefit.
Yeah.
So if Mr. Woodley is saying is, when that's displayed outside the exchange, that looks the same way as somebody who's offering embedded, then that could be a solution.
Well, and the other part I would make, again for the record, Steve Woodley, is that there's an inherent difference between the standalone pediatric dental with respect to annual maximums. That's important to keep in mind, because when you're a carrier that has to embed the dental, the pediatric dental, as part of the medical plan in the non-exchange world or the exchange world, you're no longer subject to maximums, because the law says you can't have annual or lifetime maximums. Now you could have a child with presenting with major dental issues that could come in and basically, it would be an unlimited. It would be very difficult to price. It would be very expensive. So I think the carriers looked to the pediatric dental because in that world the law says you can have a reasonable limit for an annual maximum, which could be qualified as 1,000 or 2,000 and subject to other rules, which if you put it as part of the medical plan, it's an unlimited benefit. It's treated just like the other issues within a regular essential health benefit plan. So that would be something, as a carrier, you're having to figure out how to rate for just an unlimited dental benefit with a child presenting with multiple problems.
But that's the nature of the pediatric benefit
That's a weird
because
thing.
when you look at it, there are no dollar limits on it. It's based on the reasonableness of how many times in a lifetime, you're going to restore a tooth, or how many crowns you're going to pay for. So it's not. I would have less issue putting that in a plan because it's very well circumscribed along what makes sense. And those are put in place because for the same reason that medical says you can only have your appendix out once in a lifetime. So, I'm serious. You won't believe
Yeah,
me.
what
That's
has
why there are
affected me?
edits for that in the claim system.
So let me summarize then. You're suggesting that all the QHPs within the exchange have embedded pediatric dental.
What I'm suggesting is to not assume that standalone dental is 100% is a mandatory requirement. So that what I'm suggesting is not to restrict the ability of the QHPs in the exchange to embed. That's all I'm saying.
They're not
If it-
embed?
if
So if we just everybody, you know, I sort of a light went on, and I'm not sure if it was the wrong colored light or not. It sounds like this conversation is just the same conversation we have about mandates. That you know, why does a man have to buy pregnancy coverage and why does a woman have to buy prostate coverage? And the reason we do that is because we spread the cost over the entire healthcare system, and we've decided that's an appropriate thing to do. So maybe the answer here is just to require that pediatric dental services be embedded in all plans. Is that an option for us to just require that? And is that okay with people?
That's
Is this still open for comment? Public
No.
comment?
not yet.
So-
It's-
This is, oh, go ahead.
So, I'm not suggesting that standalone dental be put aside, because obviously it's provided for inside the exchange. What I'm suggesting is that if a carrier wants to embed dental in their own product, that be allowed to happen. And that it's up to the carriers to participate in the exchange. If someone doesn't want to embed dental, that's fine, they don't have to embed dental. I don't want to restrict anybody's ability to do their business inside the exchange or outside the exchange. And so that's what I'm saying to you, is that, and the only caveat I would make to that would be that if that is the decision or the recommendation that goes forth, then we may want to look at the number of plans that we were going to let a carrier put into the exchange, because you might want to increase that if somebody was going to have embedded dental in some and non-embedded and not have embedded dental in another.
And let me just take it a step further. So the exchange allows the carrier to bring in two plans, one embedded and one without. And we have a family that's on the individual market that chooses to go for the plan without, and then would turn and look to the exchange for the standalone dental.
If they
that would
chose
pick-
to buy it.
But if they've got children, don't they have to buy it?
No. CSIO says they don't have to buy it.
They can attest that they already have it.
Inside the exchange, that's what's so hypocritical.
That doesn't make any
It's required
sense.
for inside, it's mandated outside.
Right.
Right.
Yeah,
It's
it should be
mandated coverage.
I know, makes no
outside.
sense.
It is required, just as you said, required to be offered inside.
But you don't have to take it.
Right.
You don't have.
But they don't have to take
But
it.
outside
If you're in
the
the,
exchange, you
if
do.
it's outside, you have to buy it, but inside you don't.
So to
Or at least
clarify,
claim you don't.
CSIO has indicated that an exchange can require purchase of the pediatric dental, so that is allowed. And
So would life be would life be simpler if we mandated it inside the exchange and made things the same across the whole market?
Yeah.
I mean, if we just simply said, okay, you are required, health plans are required to have pediatric dental services in their QHPs, then it's same inside the market, same outside the market. There's no adverse selection, and then the only issue comes back to the original one we had 2 or 3 or 4 or 6 meetings ago, which is just making sure we're transparent and that people understand. Well, actually, then there's no issue, because then no matter what they're looking at, they all have dental coverage. So then there's no issues of transparency, because whatever you buy, you're buying pediatric dental services, right?
I would just, this is Alicia.
Is that a board member speaking? This is not public comment. Dr. Klein, do you want to follow up on that just a little bit more?
Well, for a simple-minded person, smart as Dr. Ash Jackson, at least when it comes to insurance selection, maybe in pediatric oncology, but if we just keep it simple, and guess what? Get over it. If you're a man, you have to buy pregnancy coverage. That's the nature of health insurance. If you're a woman, you buy prostate coverage and breast cancer. If you're a man, you buy breast cancer coverage. So it's a mandate. Deal with it. So maybe if we just say you have to have it in the plans in the exchange, then everything is the same inside and outside, and there's no issues of transparency because you're comparing apples and apples throughout the exchange. Does that just not work?
For the record, John Hager, if you allow embedded dental and you have products that don't have dental embedded, the comparison does become difficult, and we can figure out some solution if that's necessary within the next 144 days.
We don't allow them.
If you don't allow embedded dental, you can.
No, we do. We don't allow non-embedded.
He's looking at different choices.
Yeah. If you.
I'm saying require. You're saying. Sorry to interrupt, John. You're saying that CSIO will allow a health insurance exchange board to mandate that all plans within it require embed pediatric dental services. Is that correct?
No, that's not correct.
All purchases.
Not correct. Okay.
CSIO prohibits an exchange requiring all medical QHPs to embed dental because that would push out of the exchange the standalone dental product. But CSIO has also said that if you have medical plans that don't have dental embedded, which would by default mean that you've got standalone dental plans in there, that you could require the purchase of the standalone dental plans. So you can require purchase of standalone dental. Just that's an important clarification to make. We cannot require every plan to have dental embedded, but we can require the purchase of standalone dental for every member who purchases a qualified health plan.
So that's what I'm saying, so pediatrics. So you either buy an embedded plan that has the full array, or you buy a combination of the two. But it doesn't let you out of the selection until you add, if you've picked a non-embedded plan without adding in the peds dental.
Okay, what if you don't have children in the family?
Some states.
Aren't you still required to buy it?
They don't really care if you don't have
Not required to buy
children.
it.
The risk has to be
No.
pushed across
Yeah,
the
it has to be
entire
spread. Yeah.
population, which is Dr. Klein's point.
Lowers the cost.
Pregnancy,
Right.
prostate screening, and everything else.
Right.
And I don't think you can discriminate and say only people with kids have to buy it, because now you're discriminating.
And just to be clear, to kind of circle back, the reason, so the original recommendation and policy of the board was to only allow standalone dental products. And even the writers, the intention was to allow them as standalone dental products. And the original decision was to not require purchase. And so that's part of the reason why we came with this recommendation, because it was as close to the original recommendation, it just eliminated the rider piece of it. I'm still trying to struggle with how we would do it if we allowed dental to be embedded. But the piece about the individuals and employees seeking dental coverage as an optional purchase, that if we require that to be purchased, that's an easy change to make technically. So that would be easy. The difficult technical piece would be providing the option of both embedded and non-embedded dental.
I guess the question that first comes to mind is, if I've got an individual coming on the exchange, even individual or married couple without children, and I'm forced to buy pediatric, do I impact my enrollment potential by doing that?
Any time that if you're going to require a purchase, that means that, well, so there's a couple sides to that. So if you're going to require purchase of something, when you purchase something else, that increases the total cost, and that could impact enrollment. The other side to that is, let's say you have a family who makes very little money. Let's say a premium is $100, and let's just say it's an individual. Let's say it's a child-only person, 20-year-old. Let's say that they can purchase a medical QHP for $100, but their income is such that the amount that they would pay is only $25. If you add the medical, so their subsidy would be $75. if you add let's pretend a $20 dental plan, I don't know if they're $20 or $40 or whatever the market might say they are, but let's say they're $20. So the price went from $100 to $120. That plan covers the EHB. It's all subject to the APTC. Based on the way that the rules are designed, that person is not supposed to pay more than $25 for that second lowest silver plan. So that subsidy would be adjusted from $75 to $95. So for that person, there would be no price impact because the subsidy would cover that cost. Now, when you're talking about somebody that's unsubsidized, it would increase costs and potentially impact.
But you've already increased cost if they chose to go outside the exchange and purchase, because CSIO has said that you must embed that regardless of whether or not they need it, and now I'm back to my lie thing, or they have to attest that they purchased a standalone QHP either inside or outside the exchange. And we're not going to let somebody purchase dental only inside the exchange. So you're already sitting at a place where you're asking people again to misstate what happened. I'm not going to use lie, but lie about what they intend to do or they've done, or pay for it anyway. I mean, the intent of this law is to create a community rating by demographics for all services that are considered to be mandated for the good of everyone else.
You understand her?
And so you're already disadvantaging them inside or outside.
You don't understand it either.
So why should they be advantaged inside?
Do you understand?
The other problem I said as I had was that if the intent was to get these kids taken care of, how can you let somebody go in and not buy it?
So John, Steve Woodley for the record. So can a carrier, to your knowledge, leverage the standalone pediatric dental carrier's offering on the exchange to satisfy their requirement outside the exchange?
Yes.
Okay, thank you.
Dr. Klein, any more comments or questions from Las Vegas?
I'm going to go home and replay this until I understand it.
Yeah.
No, I have no more.
Well, if members don't object, I'm going to open it up for public comment at this point. So is there...
Can we ask that anybody who does have a suggestion that look at the recommendation part on how that should be worded? Or that's really what's going to come out of this, is whatever we do about rewording the three sentences in the recommendation, whether it should be may or may not be embedded in the QHP, whether it should be required for the pediatric, whether or not the standalone plan is only pediatric.
And I believe that a number of states made it mandatory across all ages and all plans.
So that dental was mandatory, whether you were pediatric or adult?
Correct.
And that goes back to Dr. Klein's point, that
Yeah.
when you buy a medical plan, you can't pick and choose to not have maternity, whether you're a man or a single man. So it's the same methodology, same kind of concept.
No, I don't have difficulty with that. I was going to say it, but he said it first. But,
yeah, sure.
No, you said it much more eloquently, but I kept thinking we're trying to spread the cost so we pick up the pediatric part.
By the way, Dr. Klein, I'll defer to you in pediatric oncology.
Thank you.
For sure. And unless anyone objects, let's move to public comment on this item. Is there anyone in Las Vegas that wishes to comment?
We're all dead down here. Yeah, okay.
We've got somebody.
Oh, there it is. I'm sorry.
We have a comment.
If you will identify yourself
Talley.
for the record, please.
Yeah, Dr. Talley, Nevada Dental Association. I'm trying to wrap myself around this like everybody else. It seems to me like what you want to do is require people to purchase the standalone dental plan or the dental plan. If we're trying to get the kids covered, you need to require that they purchase it, not just require that it's offered, but require that they purchase it in the exchange, because it sounds like it's already taken care of outside of the exchange, but in the exchange, it's just required to be offered, whereas I think what you're saying is the government will let you make it mandatory inside the exchange, and it sounds like that's what you need to do.
You can't make it mandatory. You have to
All
offer.
right. Thank you. Do we have anyone here in Carson City that would like to testify?
I said you have to offer it. No, because I asked that question. They said you have to offer it. You don't have to purchase it inside the exchange.
For the record,
You can't.
with the dental insurance company. So there's a lot that you covered. I'll start with this. I agree that there's inequity in the markets, and CSIO has written some rather arduous rules around this. I will point to 3 states, Iowa, Wisconsin, and Colorado. And the outside market is regulated by your division of insurance. It's not you guys regulate and have control over inside the exchange. So this would be an issue for them that they could look to those 3 states who have said in bulletins the mere presence of a standalone dental market outside the exchange is reasonable assurance in and of itself. A QHP can offer a 9.5 product outside the exchange, put a notice on that product that says this does not cover dental. So that makes it not a required purchase for childless adults outside the exchange. That is at their discretion, because the Division of Insurance in every state regulates the outside market, and they consider that to be reasonable assurance. So that would be one thing to consider. What your discussion has been is that is set in stone outside the exchange, and so you have to adjust to that inside the exchange. These divisions of insurance have said, no, we don't like required purchase for adults because you're making them buy something that they cannot use. And that is not a fair. Now, it's true that people in their medical policy pay for maternity and prostate and things like that, but there are no standalone plans. There are no standalone prostrate products out there for this discussion to be had. There are standalone dental products. There are standalone vision products. So that the whole essence of saying embed it all into a QHP, while it's very easy on its face, it reduces competition. It will disrupt existing markets. People who are in a small group today that have their dental through a standalone dental product will be forced out of that product, and perhaps their provider, if they are pushed into the exchange, where the exchange is saying it's a required purchase for everyone, and the embedded is the best way to do that because we can spread the price over everyone. Because we know that only people up to age 19 can utilize that product. So we can say, well, we've got 75% of our population is above 19, which is a rough estimate, but about there, who aren't going to use this product, but you're going to pay a premium for it. And so we're going to drive down the price of that, and we're going to have a higher out-of-pocket maximum, $6,400 for an individual, $12,800 for a family, and a higher deductible in the small group market of $2,000 for an individual, $4,000 for a family. So if your first dollar coverage is for dental, you're going to pay 100% until you hit either $2,000 or $4,000 in an embedded product. That is the advantage of standalone. We do not have a set deductible, and ours does range from $50 to $100 roughly. And we have an out-of-pocket maximum of $1,000 for an individual, $2,000 for a family. So if you are in a pediatric child who has medically necessary ortho needs, you are not going to have to hit $6,400 or $12,800 of out-of-pocket maximum money. You're only going to have to hit $1,000. And after you hit that out-of-pocket maximum, your coverage will be 100%. A huge advantage to that dental need that would not be serviced under an embedded product. So it is a difficult, I know, issue. There are advantages to embedded and to standalone. I would say, and I would repeat, I've been on the record before, we are not opposed to embedded products. We just say that if it's embedded, that it be offered medically only as well, so that the consumer will have the choice to say, yes, I like that medical plan, but I don't like their dental. Their network is 50% of a standalone dental plans, and I want to go for either continuity or competitiveness or just because I like that plan. At least give them the option. They don't have to take the option, But if
Yeah, a little
if
bit.
it's all embedded, it's take it or leave it.
It's between inside and
Do
outside.
you have any recommendations on language for this item?
Well, on language, I mean, really, your recommendation revised to indicate that the pediatric dental may not be embedded. I would say that that is fine for it to be embedded. It's really going to be around the equality of both embedding, providing a medical-only policy, so that the standalone dental policy at least has something to be partnered with. Otherwise, standalone dental won't be in the exchange. There's no purpose for us to be there if we're just competing against embedded products, because you have to buy it twice. So as long as there is that apportionment, really 3 columns: embedded, medical only, dental only. That makes sense to us. And as far as required purchase, as I said previously, I would say you can require the purchase, certainly. I would limit it to the pediatric population, however.
Right,
Not
exactly.
the adult population.
Agree.
Madam Chairman, I just want to clarify 2 things. The first thing is that there's nothing in the law that says that you can't have separate deductibles or benefits that separate dental from any other benefit. So that there's nothing that says, I would
Maybe it may
give you
not
a
be.
parallel. We looked at, we all have to embed vision in our products. We looked at the cost and the intent of the law in terms of applying a similar deductible to a vision product as might otherwise be in place. It makes no sense to do that. So the vision product could be offered at an appropriate level, a 0 cost if that was the choice, or a $25 copayment. So there's nothing, I want to correct this gentleman's expectation that it'll be $6,350 if somebody has an HSA, or $2,000 before they get their dental benefit. That is not necessarily true. It's up to the individual carrier. And then the second thing is that I have no problem with, and I would think it would be problematic to force embedded only. You need to, I would recommend you need to have standalone with medical. The issue is that everybody buys however the package is completed. Whether or not it's a sum of the 2 products or it's a single offering by a particular carrier, the products are available. And I do think when MedAdvantage comes in, there are so many boxes that you can click that look at the network, that look at the cost, that look at everything, and then people make a decision not just based on the cost, but based on the services and the network. So I think there's opportunity to do both. So my recommendation would be, and and I don't know if we have to vote this one down, but my recommendation would be that we ask that everyone in the exchange be responsible for purchasing coverage that included pediatric dental and the essential health benefits package, and that can be performed by standalone dental and a product that does not have embedded dental, or a product with embedded dental.
So all 3.
That would be my recommendation.
Do we have any more public comment?
I have one on the phone. Is it available?
We'll come to the phone in just a moment.
For the record, Dennis Spain. This has been really a very enlightening discussion. It also points out how complicated this issue is and how difficult it's going to be to get the language right and get the market balance right. I've made a recommendation before, and I'll repeat it again, that I think it would serve the committee well to have a subcommittee devoted to dental issues to sit and parse this along with the Department of Insurance. Or the Division of Insurance. I'd like to talk to what their opinion is along this. I think that you can have standalone dental. You can have standalone dental offer a rider to a medical carrier that does not have a dental plan, and you can have a medical carrier that has a dental plan. for her organization, it's going to be really difficult to say, well, I've got dental in the network, but or rather outside the exchange, but I don't have it inside the exchange. And how are you going to cut that? How are you going to do that surgery as you do it? The final point is, and this is 2 points. One, let's don't lose sight that the whole idea was universal coverage for kids. Is the number one issue. We can't open these doors because they're technically difficult that allow kids not to get the coverage. The point was to get the coverage. Second point is that embedding has other benefits besides the economic issues. You have relationships between prenatal care and the dental operation. You have diabetes management that occurs in both sections of your unit. Being able to work together is really crucial to how we're going to lower healthcare costs going forward. And dental participates in that. And so to set up an artificial barrier here, I think is not going to serve us well. And I think the committee's on the right track. I'd be happy to work with you on the language, but the idea is let's get all the kids to have the benefit, and we'll work out the logistics. I can get an HTML programmer in, we can do the screens. That's not that hard. But the hard part is to really get us all committed to kids having the benefit. Thank you.
All right, let's go to the telephone. Any public comment there? And if there is, could you identify yourself for the record, please?
My name is Alicia Smith, and I'm with Premier Access. So I just want to make a recommendation for the language. So it says, be revised to that the pediatric dental EHB may be embedded in the QHP. Individuals and employees may seek dental coverage through the purchase of a standalone dental product or an embedded dental product in a QHP, and then purchase of a dental is required for under 19. So we would just mirror the idea that all kids should be required inside of the exchange to purchase dental product, and they can do it through a QHP with an embedded product, or they can do it through a QHP with a standalone dental product.
Okay, thank you. Is there anyone else on the phone that would like to testify? All right, we'll close the public comment on this. Mr. Hager, you wanted to?
So it sounds like everybody's advocating completely reversing the decision we made 2 months ago. And we have
Well, SCIO changed its mind since that decision was made as well.
Yes, right.
That's why we're thinking about it.
Considering riders not standalone. Yeah.
Around inside and outside and allowing an attestation and all that other stuff.
I think that was made right before
Okay.
that. The only thing that I know of that
Hey,
has
we didn't
changed-
understand.
The only thing that I know of that has changed since then is that we can't offer standalone dental products as riders.
Okay. And is that SCIO or Division of Insurance?
I think that.
It's the OI guarantee issue.
Well, I think it's, yeah, I mean, I think it's an interpretation of the SCIO. I think it's SCIO. I don't know, maybe, can we ask the DOI to come out here?
Yes, please.
Didn't see you back there.
Do we have Scott?
We welcome your testimony.
Very timely.
For the record, Annette James with the Division of Insurance. Could you repeat your question? I want to answer it exactly.
Since we made our decision, since the committee and the board made the decision to allow dental riders to be offered as standalone dental products, we've had discussions that indicated that riders could not be certified as standalone dental products, and they'd have to follow all the same rules as the plan itself. The question from the committee, I think, was that a SCIO change, or was that the DOI's? What has changed since then?
Interpretation. Okay, for the record, Annette James, Division of Insurance. we have, within the last 2 or 3 weeks, we've received a lot of sub-regulatory guidance from CSIO. And one of the areas that we've received guidance from is pediatric dental. There are several issues, and you did a good job of articulating some of those issues with having pediatric dental as a rider. The basic idea, though, is that the Affordable Care Act really did not contemplate having an optional rider for any EHBs.
She's saying that they should allow it
They
vetted as
would
well
be,
as
because the
standalone.
whole idea is that they're required.
exchange, that would be a
And so
problem.
there were several issues with having that optional rider. We had asked
Need
CSIO
it?
for guidance on several occasions, and essentially, finally, they came back and said, the law does not preclude having an optional rider. However, the law does not accommodate having an optional rider. So what that meant was that it would be difficult, impossible for a state to certify an optional rider. So that's a back kind of roundabout way of answering the question. Although the law and the regulations do not preclude having an optional rider, pediatric dental as an optional rider, it does not accommodate it. So it cannot be certified, essentially. The other thing that I would mention is that for federally facilitated marketplaces, the federal exchanges, they do not require, they do not allow riders for, they just do not recognize riders. Either the benefit is included in the medical plan, or it's not.
So would it be a standalone then that you'd have to reach to comply with all the essential health benefits? then?
So for in the federal exchanges, my understanding is what they're allowing carriers to have option A and option B as far as for a plan. So option A would be having the pediatric dental embedded, and then option B would be having the having the same plan without pediatric dental, and then you can always add the standalone dental.
Are they requiring in the federal exchange those individuals who do not have children, are they requiring them to buy the pediatric coverage?
You know what, I am not certain whether purchase of pediatric dental is required on the federal exchange. That's something I'll have to check on that. I think it is, but I'm not absolutely certain.
Yes, Mr. Woodley.
For
Would you
the
stay
record,
here with
evening.
us?
So, Ms. James, to the point, and I don't know if you were in here when the gentleman was up here, I believe, from Delta. Are you aware of the 3 states, and I don't know if they're FFEs or not, who the Division of Insurance in those states allowed flexibility for outside the exchange world to be a mandatory offer and simply state within the context of their small group or their individual plan that this particular medical plan does not cover dental. However, you have the option to purchase it from the exchange or from some other source. So apparently the DOI in those 3 states, Iowa, Wisconsin, and another state, were able to do that. And so my point would be, it sounds like they didn't get pulled back from the feds where they said you can't do that. So it's opening a door, and I'm wondering if you had heard that. And then secondly, if in fact there is flexibility in that area, would the DOI be inclined to entertain that in order to bring parity? Because this is what we're in the conundrum is, in the exchange, it's mandatory offer, not required. Outside the exchange, to our knowledge, is the way I understood it, is that it is required. Whether you're a childless adult or not, you still have to get the pediatric dental. But if there's flexibility at the state regulatory level, which regulates insurance generally, and we have a mandatory offer in both environments, that solves a number of issues, and I just was curious about that.
For the record, Annette James, I am not aware of that flexibility to states, that states would have. That's something that I would have to go back and research. But I was not aware of that flexibility, or that those 3 states had decided to exercise that flexibility. I was not aware of that.
Do we have any other questions for Ms. James?
One quick question relative to writing.
You need to identify yourself for the record, please.
Maybe I'll sit aside to ask the question. Trying to find it myself, so I'll just ask it. Dennis, for the record, Dennis Spain again. Is it possible for a QHP standalone dental to offer a rider to a medical plan who does not have an embedded dental? And so therefore, the rider is now qualified to go to anyone who wanted to purchase it that didn't have access to a dental.
I'm sorry, you're confusing me. So, this is Annette James for the record. You're saying that the medical has a rider, the medical plan.
It acquires a rider from a dental plan. So let's say.
Are you in the exchange or out of the exchange?
I'm in the exchange.
Okay.
I'm talking in the exchange. I go through the hoops. I'm a QHP dental standalone. All right. She has an embedded dental plan, so she doesn't need me, but you don't. Can you make an agreement with me to provide your dental for you as a rider on their policy, and I would still be qualified as a QHP, and I would also be available to her plan, which needed a dental plan?
Okay, so I think, for the record, Annette James, I think what you're talking about is considered to be a bundled product, where the QHP makes an agreement with the dental provider to offer a product in conjunction with that plan.
Right.
Yes.
Okay, so then I want to be very careful about the words I use here, because I would not use a rider, the terminology rider, because the way that it could work is if that product, the dental product, would always be associated with that plan.
Right.
So it would not be optional. So at the point of purchase, you purchase the bundled product, or you don't. So if that's the case, then yes, that would be allowed.
For the record, John Hager, so basically that is what the committee, then the board approved, except the rider terminology was incorrect and it should have been bundled.
Okay, so no, for the record, Annette James, that is not what the committee approved and the board approved. What the board approved, and I need to be very careful here, the board approved a rider. So at the point of purchase, the individual could determine whether or not to purchase the medical plus the dental, or just the medical. That is what the board approved.
Okay.
What we're contemplating here is a bundled product where at the point of purchase, the individual would be presented with, for all purposes, it's an embedded product, but it really is, it's bundled. You can buy the package or not.
Right.
You're not allowed to buy part of the package, which is what was approved before. Does that clarify for everyone?
So since we do this, we have to do this since we don't have a dental product. If we have an agreement with a dental provider, we have an agreement with a vision provider, all those benefits get put in to the evidence of coverage and the summaries of benefits. we're responsible for making sure that that it is sold as one, and that the services that those people are providing are my responsibility or the health plan's responsibility to make sure they're done appropriately. But I think that's the way, so if you want a bundled product, we're calling it embedded because it's sitting inside the summaries of benefits, but it's not an add-on.
So is it embedded in the sense that it follows the same rules as a medical QHP, or is it certified as a standalone dental plan?
I think, for the record, and then it has to be, the dental part of it is a standalone dental product, so it would have to be certified as standalone dental.
Which would mean there's no unlimited benefit there. The $1,000 reasonable annual maximum would apply as a bundled product.
That's correct.
Okay.
And
That's my understanding.
And there's no problems with the guaranteed issue provisions for these products because they wouldn't be offered to other individuals who purchased another medical. So so you're going to certify that dental product as a standalone dental product, but you're not going to offer it to anybody other than those who purchase that medical QHP.
So the way it would work, though, is that you cannot separate the two pieces. Once they're combined, you cannot separate the two pieces. The difference is what the board had contemplated or approved before. It was optional.
Okay.
And so this would not be optional. Once it's associated with a medical product, the pediatric dental could not be separated from it.
But the
So that would be
plan,
embedded.
but the plan chooses,
Bundled.
but the plan chooses how it wants to apply the benefits. It rolls up, it all rolls up to the maximum out of pocket in terms of the patient's portion, however we decide to do it. So for the sake of argument, if we decide, if we have the essential benefits, if we decide that those essential benefits are to be set at some percentage in aggregate, we can choose to assign $100 to that product as deductible and then add it back up into the beginning. We can choose to assign $0 to that deductible as long as the whole plan meets the actuarial value.
So it's not standalone. It's
No, it's not standalone.
Well, it's
not standalone.
James from the division. Once it's bundled, it's embedded.
Right.
It can be offered also as a standalone product. So I needed to make that clarification. So it can be certified as a standalone product. It can also be embedded. And bundled, pardon me. I need to be careful with my terminology. But the whole point, though, is that when the actuarial value of the plan is calculated, it includes pediatric dental in that calculation. So bundling the product and by bundling, again, you cannot separate the two. That bundled product is what is going to be run through the the actual value calculator. And adding the dental part of the bundle does not change the actuarial value.
So for the public purchasing, because of the tenderness of the federal government making these easy decisions, which we're having so much fun dealing with too. They're going to buy a product, and if the qualified health plan has dental coverage within it, however, whether it's bundled or rebundled or contracted or whatever, for the purchaser, they're buying one product. And so whether that's embedded or not, I don't know, whatever language you want to
Sold
invent.
together.
Whatever we want to invent for that. But that's one option. The other option is that the qualified health plan does not directly provide the pediatric dental, and that can be purchased as a standalone. Those are the two options that are available, right?
Mm-hmm.
And let me make a point just to clarify, so.
No, last time you
No,
clarified it, we went on 30 minutes. being confused.
It's always helpful.
Yeah, this is
to
the chair's
wonder.
call on this.
So a bundled product, as I understand, that is whether it's Premier or Delta or whomever. So I'm the medical carrier. I have a relationship with my bundled dental carrier. The bundled dental carrier controls those benefits. I can't tell Delta that their maximum benefit is unlimited. I'm the medical, I'm subject to the medical rules. I have a business relationship as a bundle with Delta. Delta can say the annual maximum for the dental benefit is $1,000 and this is the deductible. I don't have the authority to tell my bundled partner what that benefit would be, correct?
Dennis Spain again. The working model that I've been doing this since 1985 in Nevada is what we use with the Taft-Hartley Trust Funds. That is, I am a freestanding dental provider. I go to the trust fund and I provide them a benefit. We negotiate what that benefit is going to be, and then they contract with me to provide that. I provide that for Culinary Health Fund, for Teamsters, for laborers, for whatever down the road. Each one may be different slightly, but each one is a negotiation with the overall health plan, the trust fund. And so that would be the model that I would propose here, is that if a health plan doesn't have an embedded dental product, they don't want to build one, and they can contract with us, and we will come in and make it work seamlessly. Now, and part of the places where this has to work, and why it's so important to get into the weeds on this, is what do you do with eligibility, and what do you do with premium accounting and grievances and stuff like that. That all has to be worked out in this process. In the end, my prediction is that these will be lower cost events. This will drive down the cost because there'll be synergies as the two things begin to work together, both in terms of preventive health strategies as well as the experience we have with the plan. So I think we have a working model. I don't know why.
So to your point then, if I have this bundled relationship, and again, Steve Woodley for the record, so I have this bundled carrier that I'm working with. As a health plan issuer, I have the leverage, I have the flexibility to either make it be an unlimited benefit up to $6,400, $6,350 a year, or I can simply default to what a standalone pediatric dental says. For pricing purposes, I only want to have a $1,000 annual maximum. So I can go down either path with my bundled relationship with my carrier. Is that in fact?
No, because you can't go to the maximum as part of the PD.
Well, that's what I'm hearing. That's why I'm trying to reconcile the conflict.
Okay, so for the record, Annette James, Division of Insurance. The old rules may not apply. I think what we'll have to do is look at what CSIO's regulations and also the sub-regulatory guidance says, which there's been a plethora of sub-regulatory guidance in the last couple of weeks. So I would have to go back and look at that guidance to see exactly how bundled products will be, what rules will the bundled products will be subject to. So I hesitate to answer that question definitively, but I just want to say that we're in a different world now, and the way we did things before may not necessarily still work.
All right, I want to just take a break here just for a minute, because and this is a really important discussion. I don't want to shortchange it, but we have the full board in 60 minutes coming in here for our meeting, and
So much for your other
we're
board meeting.
short on time
In
from a
more ways than
technical.
one. Before we get off this, before we take a break, So this committee made this recommendation 2 months ago, and had it made any other recommendation 2 months ago, I would have said, great, we can do this, no problem. If the committee decides to make purchase of standalone dental products mandatory, we can do that, no problem. If the committee decides that it's now going to allow embedded products, first of all, I'm not sure in the next 29 days, and perhaps carriers can provide the next 29 days before the plans are due. I'm not sure if we can change course in the next 144 days and be operational on October 1st if we make this change now. Now, the board has decided that it would review all of the plan certification policies, all the policies, over the next year and determine if we need to make a change. And I understand the discussion about how this could, the synergies and how the different options are, and that there are ways that Medicaid Advantage does it. We have been going down this road now for 2 months, and if we make that change right now, I cannot guarantee operational effectiveness on October 1st. I'll do my best, but...
John, I'm confused. This is Ron Klein. I'm confused again. So story of my life. I'm confused still. Did you not just say that we can require purchase of pediatric dental plans? Didn't you just say that?
We can easily make a change to require that if you purchase a plan on the exchange, that you have to purchase a pediatric standalone dental benefit. But
and are you and that's where we were before, but so the issue was a guaranteed issue, which that if you had a standalone dental plan, that meant everybody else could purchase it as well, and that had some implications that I'm still not quite sure of that concern Dr. Ash Jackson. So if we say you must purchase a pediatric dental plan when you go on the QHP, that doesn't alleviate Dr. Ash Jackson's concerns. Those are her concerns, right? Am I correct?
I think, well, I'll let Dr. Ash Jackson talk about her
Okay,
concerns.
so
Sorry about
my concern was, as I said, not so much from Hometown's perspective, but from perhaps some of the other carriers' perspective about the market competitiveness of giving all of the business to the standalone plans. But if you make the purchase of the pediatric dental mandatory regardless of age as part of a standalone plan, then that at least levels some of the playing field for the small group and individual market who are forced to come up with a benefit plan that includes pediatric dental on the outside.
But that, Larry Mathias, but that only works if we're allowing for competitive options. Otherwise, we're simply requiring everybody to buy a standalone dental plan, which is one.
There's four carriers.
Four. I don't see that as competition, actually. I see that as a very much disruption in the market.
But the other option is, Steve Woodley, that you could be a medical carrier that has a bundled product relationship with whomever carrier you want to have.
But John says that he can't pull that off.
He's saying operationally he can't manage that. So, right? You can't guarantee that it will be flawless.
We will do our best to be operational October 1st. This is a big change in our system design. So the way the screens go, you purchase a medical QHP and then you purchase a standalone dental plan. And whether that's optional or mandatory, that's an easy change. The difficulty is going from, now we're going to say, all right, you're going to embed dental, so you're going to have, or make them bundled. However you're going to do that, there's going to be plans that have dental and there's going to be plans that don't have dental. So you could show, all right, this plan doesn't have dental, this plan does have dental, but now your prices are going to be different. If you choose a dental plan, then you don't go to the dental plan selection screen. If you choose a plan that doesn't have dental, you go to the dental plan selection screen. But now the premiums, because if we're saying that embedded plans will be cheaper than the total of the parts, then now you're selecting a dental plan and you may be more expensive than over here. I'm not. Whoa, did we lose him in the?
12:30. I would imagine they got cut off at that time down in Vegas. because they reserved a room for that hour.
For,
Are you guys still on the phone?
Or we don't.
Do you have Dr. Klein's number?
Alicia with Premier Accesses. I'm not sure if you're checking for board members.
Yeah, we are. I think we just lost our live feed.
Yeah, it's a scheduled call, so they actually end them. If you want to text Dr. Klein or something like
Here,
that,
he's on
you
the
probably
phone.
have to dial back in.
Hello? Yeah, they cut off the feed at 12:30.
someday we'll have our own room.
I think,
Can they dial into the number that's on the agenda?
do you guys have the call-in number where you could,
We need at least one of them on the phone.
No, the front desk person got it. He's going to set it up.
Talking about the call-in number?
yeah, would you mind calling in and?
This is Rose Park in GovChaw. I have the call-in number.
Yeah, everybody's got it on the agenda.
Okay.
It's 877.
The problem is, John, is that, I assume we're all doing it. The problem is.
That's it, with the access code.
You're waiting for binders for June 7th.
Yeah, okay.
We've
Talk to you in a minute.
people, you know, we have pricing, you know, and we just type those in.
So it's not like standalone dental, that's mere.
We can't make a difference. We can't.
Okay, got it. That's all I need.
You have to make some.
Well, I mean, I can make a decision based on this. Writers are not allowed. So the original decision stands that that it won't be embedded and that dental plan is optional. I mean, because that's what the original policy was.
Ron, are you on the line?
And I have to come back and be a real pain in the ass in the afternoon for you. Sure.
Ron? Ron, are you?
Yeah, we're here. We're all huddled around my cell phone.
Oh, jeez.
See what it is when you don't pay the light bill?
Well, part of our dilemma is that we need to make a decision on something so that we can continue with the IT infrastructure and backbone on this and be able to open October 1st for enrollment.
Yeah, and I thought, you know, Dr. Ash Jackson, when he talked about, you know, having the standalones that were required, she was okay with that. So I said, okay, great, we have a solution. And then Larry Mathias said the opposite. So now I mean, I don't know if anybody has got this clear, but I'm as confused as I've ever been, and you know, on this exchange. So I don't know if I mean.
I would say that if we want to keep the recommendation basically as it is, then we can't require purchase. I would just view that as really going down the wrong road. If we open it up so that it can be part of the bundling or the contracting or the renting that a qualified health plan would do for that service, and standalone plans, and people have their options, I think that could work out. Whereas generally I think we should require it. I don't think we should require it if we're going to have this limitation. So
the limitation is that it's only pediatric?
No, that is only to standalone plans. That it can only be obtained through standalone plans, which is what we're.
So you know, one of the things that circulated down here was just taking the word "not" out of the recommendation and just basically letting plans do what they want to do. They can embed it, they cannot embed it, and there can be a standalone plan and just sort of more of a laissez-faire. Does that seem to work for you guys up there?
That's what John said is going to be very, very difficult for them to be able to pull off by October 1st.
By removing the word "not."
Yes.
Well, like by giving people the option to embed, not embed, or having standalone, that we can't do.
We can, but maybe not within the time frame.
If the committee's recommendation was exactly that 2 months ago, yes. But I understand. We've got 144 days left.
Do you
This
need
is a
to be-
complete flip-flop of what the committee recommended last time.
So the only thing.
Yeah, I appreciate that.
So Steve Woodley for the record, so within the time constraints and what we're trying to accomplish, so the only thing we really can do is just require purchase. Take the original recommendation and tack on required purchase so that there's parity outside the exchange world, and that is doable. That's an easy fix.
I can do that.
Okay.
And I can guarantee that we will review this again for 2015 so that we can potentially pick up those synergies and do what we need to do.
Who are the standalone carriers in the state, and how are we defining standalone?
It's Delta, Premier,
Guardian, and
Liberty. Yeah.
So,
And
does that mean when Anthem underwrites I don't know if Anthem's on the phone, but when Anthem underwrites a dental plan to be sold along with its medical plan, does that mean that they're not certified as a standalone carrier? Because today it's an optional purchase that they underwrite.
For the record, John Hager, so the other carriers have indicated that they have their own dental organizations, or some of them have indicated they've got their own dental organizations and that they were going to be certified as standalone dental. Now, we have not required anybody to say that they were going to be a standalone dental. They have provided us with these letters, and that helps us because we know then that the medical carriers do not have to embed it. So that's why we released the one that did it originally, and then the others have followed suit. That doesn't mean that those are the only ones. Anybody who submits,
who currently offers a dental product, for the
or
sake of argument,
anybody who is intending to offer a dental product, could be new people,
could get certified, but then there's, and I don't know what the process is for certification for a carrier. It's like when you start an HMO, you've got capital requirements, and I don't know what that means in terms of standalone dental, whether or not it's a network-only thing, or, you know what I mean, to get approved by the division. Annette, can you help with that?
For the record, Annette James, could you, I'm sorry.
What I'm trying to figure out is, suppose we decided tomorrow that we were going to rent a network and deliver a dental product, for the sake of argument. What sort of requirements would that be in order to be enabled to sell that by the Division of Insurance?
For the record, Annette James, are you talking about a bundled product?
No, I'm talking about, I decide I want to sell dental and have the broker take it in regardless of what insurance company they're selling the medical with.
Okay, so
like a startup dental product.
The startup
dental offering it as a standalone.
Correct.
It would have to comply with our statutes on dental products.
And what's the time? I'm just, the concern that I have, I'm trying to alleviate Mr. Mathis's concern about the potential anti-competitive nature of handing stuff over to four standalone products. So it still has to go through, and you're validating what my assumption was, still has to go through all the requirements that the division has to certify it as stable enough to be able to sell insurance. It's got capital requirements, quality assurance, legal, all that other stuff, correct?
That's correct.
Okay. So then then it's a question about whether or not you believe you're gonna have more people available in that marketplace than there are today.
John, could I just, Steve Woodley for the record, could I make in the interest of time, there were a couple other elements within the different documents that were addressed that I think we could probably do some recommendations and vote on. One of them had to do with parity, the network adequacy between HMO and PPO. I think that's fairly straightforward, and my recommendation would be there should be parity between those. In terms of network adequacy, as available providers, 50 too low, 95 too high, maybe 80 is the sweet spot. I think we could all probably get through that. Maybe we can dispense with.
Can you talk about what section that's in?
I broke down his notes. I just know that it was brought up earlier. So network adequacy was one, where the HMO is held to a 95% ratio, whereas PPO is at 50, and that was because that people could go out of network. And then it talked about the parameters of what's considered adequate for the network. Is it a 50% of the available providers, or is it 95%? And then we talked about a sweet spot of maybe 80 for both. So I'm just wondering if we could knock out a couple of those and then focus on the remaining part. Section 10, thank you.
Okay, so Madam Chairman, I'm going to recommend that we table this to move back to Mr. Woodley's recommendations and then bring it back up when we're done with his quick hits. If that's, unless you want to keep going.
Well, but we told we'd open up for public comment on this.
I'm sorry.
Do you want to go to another session, an emergency session, like in a week or something? I mean, if you want to put it to
I
another.
think John needs some decisions today, and we would have 3-day noticing requirements. Yep.
Can I, so the carriers that I spoke, I didn't speak with every one of them, but they indicated that because of the previous decision that the board made, that they were preparing their dental products to be certified as standalone dental products.
So you're comfortable with the fact that every carrier had the option to become certified as standalone so that they could participate if they chose to participate?
I can't say every carrier.
I mean, but
the ones that I spoke with said that they are fine with they are comfortable with the current board policy. And again, the reason that I was bringing this back was because we need to be clear that riders will not be allowed. And again, I also intend to take a look at this and see, look at the exchanges across country and see how they're doing it, and maybe we can make some adjustments for 2015. I'm just concerned about making that kind of adjustment by October 1st of this year.
So the plan is moving.
John, I would have to agree with you, and I mean, and with respect to Dr. Ash Jackson, and maybe, and again, I'm at some point offline, and we try to figure out what the concern was, but still can't get my arms around it. But if all carriers seem not to have the same concern that Dr. Ash Jackson does, then I mean, I would imagine they would have the same concerns, and they seem not to. Is that right?
The ones that I spoke to did not have those concerns.
Okay. Dr. Ash Jackson, the fact that other carriers don't seem to have those concerns, does that help ameliorate some of your concerns?
Right now, it's not me, it's Mr. Mathias who's concerned about the anti-competitive nature of having only 4 certified standalone carriers in the state.
Well, I'm only concerned about it if we're thinking about actually mandating that everybody who goes on the exchange has to buy one of those plans.
What are you going to do to cover pediatric if we're saying that
Well,
it's
that's
not
why
going to be
I think
embedded?
the idea of the rider, the idea of embedding it in some sort of bundled product strikes me as the better overall approach, because it's easier for the public to understand what it is that they're making a purchase of. This way they're having to make two decisions and try to fit them together. And we're mandating something that's
John,
going to be a little difficult.
I know that you're working with Xerox day in and day out, but do you want to have the opportunity of talking to them if this change came about before anybody
We
makes
will
a
talk with
decision?
them, regardless of what happens.
I think
Let me
we
ask
need
you
to
a
make
question.
difference
Can we adjourn this meeting and continue it?
Today, yes.
But we can't continue it tomorrow.
No, you'd have to notice it for tomorrow. I mean, unless you noticed it as a multi-day meeting, the meeting
Okay.
goes, that day. I mean, you're allowed to take a break. You know, it says on your agenda you might take a lunch break or something like that. So you can take a break and readjourn
Okay.
later this afternoon.
Well,
but-
I'm just trying to figure out
Yeah.
how we can get through this.
Well, if I understand the learning class, if I understand the concerns and the limitations, then the recommendation as it stands is something that I don't think I'm comfortable with, but that I can support, because it keeps it as optional, but the only vehicle is our option, are these standalone plans, and move forward with that.
But then you set up the anti-competitive nature of the inside versus the outside of the exchange, and you don't get to the root of the issue, which is getting the kids covered.
Yeah.
And I think, you know.
I agree.
Let me
I
have
think
Ms.
the feds
James.
have created the inconsistency.
Well-
And the feds have created two policies that don't match up. We're trying to find a fair way to deal with that. But I would hate that we would enshrine an unfair way of dealing with it.
Ms. James?
For the record, and then
This is Wayne Finch. I'd like for the record to make a comment. We should not be letting technical issues impact our decisions on such topics. Okay, we've established goals and strategies as to how we should be acting as a committee. We should not be making decisions for the ease of technical difficulties. I think that what the decision or the conversation in the last 2 hours has been around allowing the opportunity for carriers to be able to offer either embedded or not embed the pediatric dental rider benefit. Those customers who choose not to buy the QHP with the embedded dental would have to then purchase the standalone dental.
Ms. James?
For the record, Annette James, Division of Insurance, I wanted to make a clarifying statement. When the question came up about the bundled products and what rules they would have to follow, I want to clarify that any essential health benefit will have to follow the market rules. So if a QHP is bundled with a dental product, that would have to follow the market rules. The new market rules. I just wanted to clarify that. And discrepancy between on the exchange and off the exchange would be a concern of the division.
So the easy answer is just to continue the policy recommendation that was already approved by the board and make it mandatory in and out. That to me seems like the solution.
For the record, Annette James, the optional rider would not be able to be certified on the exchange.
He's talking about the recommendation.
He's talking about the recommendation.
Oh, that recommendation.
The new,
Right.
the new
That's why we
recommendation.
brought it back to the
Oh,
discussion
okay.
again.
Yeah. Okay, thank you.
So the question on the floor is whether or not it's mandatory for everyone to purchase the coverage.
Through a standalone plan.
Right, and then.
And we think that's better than not, right?
Right, so that's a
Basically, we're
question.
putting a mandate.
Right, so does everybody purchase the coverage? And then the second portion of that is, what are the vehicles by which they purchase the coverage? The preferred administrative vehicle at this point, because of uncertainty, is to have a standalone inside the exchange accompany the medical benefit. The larger issue would be offering more ability for carriers to offer a bundled or embedded product inside the exchange as well. Right? So, but that's the piece of it that we're not quite sure can be accomplished for the open enrollment period for this year.
But if we do mandate it, and we only have standalone pediatric dental as the option to purchase, then we're going to be making it very obvious to people who don't have children that they're paying considerably more for this service. I mean, it really does fracture the basic underlying.
Let me ask a question of the DOI real quick. The dental benefit, so the pediatric dental benefit, is that if we require everybody to purchase a standalone dental product, does that mean that adults would not get any dental benefit? Or would they simply not get the dental EHB, they'd get a dental product that they could use, it wouldn't be eligible for the APTC?
It depends how you priced it.
For the record, I'm at James. So adult dental is not part of the EHB.
Right.
So that would not be that would not qualify for the tax credit. Is
Right.
that the question?
Yeah. So the question is, do we require if we require everybody to purchase the pediatric dental benefit, or we require everybody to purchase a standalone dental benefit? So if you require everybody to purchase standalone dental benefit, everybody gets the benefit of the dental benefit, but only the kids, only the pediatric portion is subsidized by the APTC. Is that
No,
correct?
only the kids get the benefit.
I appreciate what Larry's saying, but I can't imagine. I mean, do we have any ballpark of if we made everybody purchase a pediatric dental benefit, what we're going to add to a premium? Because I can't think it's going to be a lot of money. I mean, we're back to the same mandate. We're back to sort of the same mandate question again, which is, men get upset because they're buying pregnancy coverage. Okay, childless adults can get upset because they're buying pediatric dental stuff, and it's right, it's a little more transparent than it usually is, but the same philosophical issue.
Well, that would be true if it was rolled together with purchasing the entire coverage. But as separated, it doesn't. In fact, it creates a stark unfairness to those who
I want the committee members to look at their calendar for Wednesday, if you might, please, because this issue is very complicated and very important. And we've got 35 minutes before we have another board meeting in here, and I don't think we're properly discussing it.
So
would everybody look at their calendar for Wednesday and tell me if we posted the same agenda tomorrow morning before 9, we can hold another public hearing on Wednesday. And then John can get Xerox in here. We can do some of and I would ask Ms. James, if you could be here also. We need somebody from Division of Insurance for this.
I'm good with that, and I also think that we need some answers just around average cost per child, for full benefits, all that.
We can give our questions to John.
And we can suss some of the stuff up.
Let's just start earlier rather than 10:30, maybe 9
Well, we thought this was
o'clock.
going to be an easy
Earlier.
meeting today. Yeah, that's okay. We need to do it correctly.
How about 1 o'clock on Wednesday?
Sure.
Whatever you want.
For those in Las Vegas, does 1 o'clock on Wednesday work?
This is Wayne Finch. I'm not available on Wednesday, so I will not be attending.
And Vicki Mayville, I do have an appointment until 1 o'clock, so it would have to be later for me, or really early.
I'd have to do it early.
You can't do it in the afternoon?
I will make myself available as best I can. But wrong time, sorry.
Or what about in the
I
morning?
can't check my calendar since my cell phone is being used for communication purposes.
Oh, yeah.
What about Wednesday morning?
Just tell me when to show up.
6 a.m.
I take my husband to the airport at 7. That's fine. I'll drop him off.
8:30.
8:30.
Can anybody do 8:30 on Wednesday morning?
Yep.
Do we have a quorum for
Yes.
that?
Yes.
Yes?
Be there.
So,
Yes.
I don't want to upset you, but you've got to carry.
Dr. Roberts is not
Or
here,
we'll do 2 different meetings at the same
so we
time.
don't know his schedule.
Okay. All right.
Do they have one person down south who can be there?
Ron, will you be able to be there? 8:30?
Yes, I will be there.
All right. we got
Okay.
5.
So
And I'll be there for a couple hours.
Okay. All right, then, we're going to adjourn this part of the meeting and reschedule for next Wednesday. I need to open it up for public comment one more time.
Can we do the network adequacy piece? That was, I think that was rather simple. We got
The two pieces about the
Bring them
parity
both to
between
the
HMO
parity.
and-
Why don't you make a
Make a-
motion? This
okay.
is agenda, well, we were going to open that up for public comment again.
Let's get this done.
Okay.
I'm agreeable with 80%.
Okay.
So I will recommend a motion is to accept the network adequacy standards provided by the staff, except that section 10, the last two bullets would be adjusted to indicate that compliance with the distance standards will be achieved if 80% of the population of the geographic service area or existing membership is within the distance standards of the providers with whom the carrier contracts. So basically, it merges them both. Any plan, any dental plan, standalone dental plan will have an 80% requirement.
If that's the motion, I'll second.
No, you're making that motion, Mr. Woodley? He can't make the motion.
Yeah. So, relying
You say
on
so
John
moved.
Hager's verbiage, I would agree to make the motion that we have an 80% threshold for either HMO or PPO, whatever standalone dental carriers are going to participate, and 80% would be the threshold.
Okay, do we have a second?
I'll second. Prioritize.
All in favor?
Aye.
Aye.
Okay. All right, that closes agenda item, then
I
number,
have one more thing on that agenda item. It mentions primary care physician, and I didn't know at the end of your narrative, and I don't know if you need to say you're not selecting a primary care dentist. You know, you're not anointing anybody as a primary care physician.
No, it's just the medical language that was pulled
It's
over.
the medical language that was pulled over, that should not, that probably is confusing.
We'll make an adjustment to that.
I'm just-
Can you get with Damon to point out exactly what
Right,
you're looking at?
okay. I just want to make it dental.
Sure.
we need to open it up for public comment before we close the meeting today. Is there public comment here in Carson?
Jim Mullen with Delta Dental Insurance Company. I'll be brief. I just wanted to clarify, the discussion has seemed to be that there would only be 4 standalone dental plans available. And that might be the case because of the word plan, but my understanding, John, if I'm hearing you correctly, is that the qualified health plans, that at least those that have a dental component, would also be offering standalone dental products that would be equally available and competitive with the 4 standalone plans that intend to enter the exchange. So you would have more than 4, correct?
Yes, there are only 4 carriers that have so far indicated their intent to offer standalone dental products on the exchange. There could be simply standalone dental plan product or carriers that have not told us yet, and there could be carriers that have their own products that intend to offer standalone dental plans. So it could be any number of carriers who have any number of products which have any number of plans.
Okay, I just wanted to clarify that.
Any public comment in Las Vegas?
None.
All right, any on the telephone? All right, I thank you everyone for your patience and participation. This has been a,
Do we need one more motion on parity between HMO and PPO?
Right.
That was the other thing, where
Right.
HMO was held to a 95% standard, but PPO was held to a 50% standard, and we talked about
did it
parity.
with 80.
Your
You just
motion
did it
covered
with
that.
80.
No, I thought that was 80% of the providers that are eligible. Is that the same? Okay. maybe
We
this
were
is-
going to just eliminate the word PPO and HMO and say
and
80%.
say 80%. Got it. Okay.
And then the other thing, just we do this in section 11, we're talking provider network requirements, again, from what, it is again referencing HMO POS. What I would say is I'd want to amend that to say a HMO/PPO provider directory must identify general dentists, because this is where the primary care thing comes in, primary care providers that are not accepting new patients.
So let's do this. I think the intent of the committee is to provide parity. If you could both talk to Damon so that when we provide this to the board today, that we got the right language, the board will approve it, and that'll be
Okay.
done.
Okay.
And do we need to do public comment again?
I mean, if you want to, just to be safe, you don't have an agenda item for commissioner or board member comments, so I don't know if anyone has any comments to add.
Any more public comment? Any in Las Vegas?
Nope.
Any on the phone? All right, thank you all. We'll adjourn the meeting. We'll see you back here at 1:30 for the board meeting, and Wednesday, I believe at 8:30. We'll get back to everybody on a definite time. Thank you all.
So I want to make sure I'm capturing correctly. We can on the last part, for the, to get rid of the primary care provider, we do one of two ways. We can designate it with an HMO PPO, or we can just say a provider. To coincide with what we're talking about, the 80% rule, it's up.
I don't care as long as I agree with Steve, there needs to be parity.
Right.
My only other issue is if
Okay.
the
And I
intent
think my boss
of
is gonna be
this
here this afternoon.
in the regular network standards,
I hope so,
was to
since
make
there's a
sure
lot that we need to
we're
do.
frustrated
Board
with
comments.
over and over again.
Correct.
To try to get an appointment.
So right now, the language I have word for word is an HMO/PPO provider directory must identify general dentists that are not accepting
Take out
patients,
HMO,
period.
we're not going to mention HMO, it's a provider directory.
Okay.
Point of service,
So,
service,
provider, so there's that one, and then the 80% rule.
Yeah,
So anywhere it says IPO, HMO, point of service, take it out.